appreciate it. Nice to see all you out here today. And I'm going to be talking about breathing patterns and a way of introducing the subject for some of our future discussants later on today. So today's the whole afternoon is really going to be devoted towards understanding these breathing patterns and interventions that we can do to improve patient care. The question about breathing patterns for me emerged when looking at the question of whether spontaneous breathing can be harmful in patients with ARDS. Several studies have shown in animal models that that spontaneous breathing can generate harm. Yoshida had two very nice studies in the mid-2000s showing that high transpulmonary pressures were able to be generated by strong spontaneous breathing efforts in an animal model. This even occurred when plateau pressures were maintained to less than 30 centimeters of water. And then he also looked at comparing mild versus severe lung injury and found that spontaneous breathing, while maybe beneficial in patients with mild injury, could be harmful in patients with more severe injury. And then this was repeated in humans and actually shows this. It doesn't look like it's transmitting quite as well as I would like, but essentially what you can see here is you have a patient at end expiration and inspiration who is spontaneously breathing and getting paralytic. And what this essentially shows, just to walk you through it, is that patients who are spontaneously breathing have increased diaphragmatic movement in the posterior portions of the lung. All right? And what this does is, because of the nature of the consolidation in these posterior areas, this dramatically increases the parenchymal strain to those specific areas. So the idea is that spontaneous breathing can actually cause specific regional harm to those regions of the lung. It also is associated with large transpulmonary pressures and tidal volumes as well. And then lastly, the transmural pressures themselves may increase vascular pressure swings and worsen vascular leakage. And this, altogether, really led to the idea of what we think of as self-induced lung injury, which Laurent Burchard and his group has coined, and I think brought into our consciousness in a different way. In addition, Dyssynchrony itself may be harmful for patients. There's associations with ICU stay and mortality, increased lung injury from transpulmonary pressure swings, tidal volumes, and potentially some of the same injury pathways as spontaneous breathing as well. And we're getting into an era now when we really need to think about who our underlying patients are in terms of phenotyping the patients because of the heterogeneity of disease in ARDS. And what can these breathing patterns, what can the underlying patterns that patients are exhibiting on the ventilator tell us about their lung injury risk for patients, what their weaning challenges might be, the response to ventilator and sedation changes, and their risks for morbidity and mortality. And traditionally, the breathing patterns have been thought of more as dysynchronies alone. And some of the traditional dysynchronies we'll briefly cover are trigger asynchronies, which are basically when the trigger sensitivity is too high for patient effort. This can occur in any mode. This is secondary to patients being too weak, not having sufficient drive, or not being able to overcome the severity of autopeep that they're seeing on the ventilator. This has been associated with prolonged mechanical ventilation and increased mortality in these clusters of disease that has been seen. And auto-triggering is, I kind of put it in different categories. This really is due to not the patient's underlying breathing activity. This is due to water in the tubing or cardiac oscillations that are causing additional triggering. So flow dysynchrony, on the other hand, is when the patient's desired inspiratory flow rates are less than what is delivered by the ventilator. And this can possibly increase patient discomfort. It's worsened oftentimes with volume control. And then by increasing flow rates or putting on pressure control, then this may improve it to a degree, but not completely get rid of it. But we had the question is, are we missing important breathing activities that go beyond this? And how can we improve our phenotyping beyond just understanding what the dysynchronies are? And so I'm just going to take a little bit of time here. This is Campbell's diagram from the 1950s. We're plotting pleural pressure on the x-axis and volume on the y-axis. We're measuring pleural pressure as an estimate based upon esophageal pressures. And we can diagram the relaxed chest wall and the elastic recoil pressure. And we can actually model almost all spontaneous breathing activity from this diagram with a lot of interesting results. In a way of understanding what the underlying breathing activity actually is with a bit different understanding. And just to give you an example of this, this is a patient who's passive on the ventilator, fully passive patient who's having inspiratory and expiratory phases that are following the passive chest wall compliance curve. And here's a patient who's having active inspiration and then passive expiration. All right. Those, of course, aren't what we're most interested in, so we'll get into some of the more interesting ones as well. But this is just showing you the concept of how you can transfer this curve into actual real-world understanding of what the patients are doing. So the first one I want to talk about briefly is entrainment, which is essentially when the patient and the ventilator are coupled with each other. This is gaining increased understanding as Dr. Beitler will be discussing shortly, and as you've probably heard other folks like Laurent Burchard discussing as well in terms of reverse triggering, which we'll get to in a little bit. But entrainment goes beyond just breath stacking dysynchronies as well. Entrainment is a very, very common activity, which we're finding in a huge number of our patients. And this is essentially, let's walk you through it. The patient has the initial passive inspiratory phase along the passive chest wall curve. They then have a diaphragmatic contraction, which is concordant in this case with the ventilator-delivered breath. You can see here that that's the diaphragm contraction has been coupled to the vent-delivered breath. And you can see actually here's a nice example that without a vent-delivered breath, no diaphragm contraction actually occurs at this point. Then the entrainment resumes on the next breath again right here as well. Right? Just one quick little point. We're finding a lot of what we think of as flow dysynchrony actually may indeed be caused by this entrainment as well. There's multiple phenotypes of entrainment, and the difference is really where the contraction occurs along the phase of the ventilation. So here's the patient has a very, very small amount of early delivered vent, and then along the passive curve, and then the patient has a reflexive diaphragmatic contraction, and then they have completely passive. This is, as you can see, is a very well stereotyped activity. Each one of these individual lines is a unique breath. And so this is the patient doing this over and over and over and over again. All right? And the key thing in this is that because it's happening according to the ventilator, this is not going to generate a reverse trigger because it's not occurring in the expiratory phase. Right? The other important thing is that we found that these were associated with statistically significant increased volumes from corresponding passive breaths, because these patients oftentimes will have periods of passive breathing as well. And then this is just highlighting how there's flow dysynchrony associated with this, or what previously was thought of flow dysynchrony. This is late entrainment, where the entire inspiratory phase is passive, and then they have diaphragmatic contraction. And the important thing is that this contraction is occurring during the expiratory phase. So this is an eccentric contraction. The diaphragm is actively lengthening while the diaphragm is contracting. All right, and that's this is the phenotype that can cause reverse triggering in particular. And then there's a question about whether or not these events could be beneficial or harmful for patients. Potentially, there's a benefit from these patients when we've seen with prior studies. There's a great study from 2017 in the Blue Journal that showed that diaphragmatic contraction during expiration could act as a brake, and that's what this late entrainment is. However, there's also some other studies that show that eccentric contraction of the diaphragm, which is this exact behavior, can then cause worsened muscle loss. And then, so the question is whether this could be beneficial or harmful. We just don't know. So quickly on breath stacking, I'm only going to briefly touch on this because Jeremy Beitler is going to talk in much more detail about this in a little bit, and we'll hear more about this. This is just to prove to the point using standard airway tracings that it's really difficult to differentiate these two breath stacking dysynchronies from each other without esophageal manometry. The first is a reverse trigger secondary to entrainment, as I was just showing. This is a double trigger secondary to increased respiratory efforts and time. This is, however, using our Campbell diagram approach, what a reverse trigger looks like. And you can see, actually, this is a nice example. The patient has one example of a reverse trigger, of a late entrainment that is insufficient contraction to trigger an additional breath. And then they have a second one, which has the additional pressure deviation to trigger a breath stacking event. You can see that there's a difference of about 150 cc's. Here's another example of it. This is just a little more standard patient, multiple passive breathing, and then a large breath. And this has been associated with large tidal volumes and transformer pressure swings in our group. And just to show you, this is a very, very common form of activity. In fact, it's the most common form of spontaneous breathing activity in the cohort of patients that we're investigating. The last thing I'll talk about is expiratory muscle activity. In the past, this has been really sort of relegated to a cycle-length dyssynchrony, known as delayed termination. But it really goes well beyond cycle-length dyssynchronies. In fact, expiratory muscle activity is really common in patients. You can see here the same diagram as before. They have an expiratory phase, they have passive expiration, then end expiration. They have this late expiratory period, and that's what we see clinically as the rounding up on patients who oftentimes have that during end expiration. There's different phenotypes that show different degrees of volume loss depending on where in the cycle it happens. Late expiratory efforts result in large degrees of volume loss, whereas earlier efforts result in less volume loss. And then you can see here, here's a patient with multiple large breaths, and then they were paralyzed, and then the volume loss that they exhibited was improved in these patients. This suggests that expiratory efforts indeed can be really important towards the morbidity and mortality that we see in ARDS patients. And again, expiratory muscle activity was very common in our patients. So in summary, we really feel strongly that improved phenotyping is needed to understand the clinical consequences of the disease that we're seeing in these patients. I don't think all breathing activity is necessarily bad. The question is if we can differentiate what is potentially not harmful or even beneficial from the ones that clearly cause lung injury. And that's going to be the key going forward, as some of the next speakers will talk about in more detail. Again, this technique has really allowed us to identify the subphenotypes, which may have a lot of clinical import. And I'm excited to see where this goes in the future. So thank you very much. This is just a little showing of the fingerprints that you can see with this pattern recognition of all the different pathways. And I didn't even include, this is not even including any of the other ones. I just didn't want to overwhelm you guys with visual data here. So thank you very much to some of my mentors, Danny and Steve, and some of the folks helping out.